Am I PMSing? Is PMS even real?
I tell patients, and when I give lectures, I say that any pain that is affecting your quality of life is not normal.
And I've heard a lot of cases of IBS recently, to be honest.
So there are a few radiologists who update themselves, or they work with some endometriosis surgeons, and they've kind of told them, like, look, this is what I'm looking for.
Another thing is there are different stages of endometriosis. So how is that defined, and at what stage should one ideally go for a surgery? And also, is it possible to manage endometriosis just without surgery?
Okay, so let's address the staging systems. The most common one that anybody who's heard about endometriosis would probably be familiar with is the ASRM staging, which is the American Society of Reproductive Medicine, which puts it as stage 1, 2, 3, 4. This is a surgical staging. It's not based on imaging. It means when you do a laparoscopy and you map the lesions and you give a score to what you find, and then you stage the patient as 1, 2, 3, 4. So it comes in the operative report. This is not a very good staging system because it does not really tell you where the disease is. It does not tell you which organs are involved. It does not tell you which other specialists need to be in the room when you're operating. And it doesn't give you any idea of what you need to do. So a lot of general gynecologists will say, oh, I did a stage 4 endometriosis, which usually means that they removed cysts from both ovaries, and that was about it, which is not what stage 4 endometriosis is. Stage 4 endometriosis, the biggest thing is when you usually have an obliteration of the pouch of Douglas, which means the space between the uterus and the rectum, which is normally free, is obliterated. That means the rectum is plastered to the back of the uterus.
Okay.
And this is usually because of some kind of bowel endometriosis in that area. So the ASRM classification is useless at best. And it is not going to, the people who actually do endometriosis surgery don't really use it except for when, if you're talking to someone about it and you can't go into a very, very scientific discussion about something like the Enzian classification, which will map disease and give scores along each part of the pelvis and outside the pelvis as well. So it looks at the pelvic side walls, it looks at the rectum, it looks at deep disease, it looks at adenomyosis, it looks at the appendix, the diaphragm, nerves, etc. You have everything covered that. So when I see MRI reports, even though the language may be in Spanish, which I can't read very well, if there's an Enzian score there and it tells me, I know exactly where the disease is and I know what kind of surgery I need to do. Whereas stage 4 endometriosis can sometimes be easier to do than a stage 2 endometriosis, which is just uterosacral disease. But if it's going very deep, it's still considered stage 2. So that kind of disease is probably more difficult to do than rectal disease properly. But so that's why the staging systems are quite useless. So it doesn't determine, we don't use staging systems to determine whether somebody needs surgery or not. What determines whether they need surgery or not is if they're symptomatic, if they're having difficulty getting pregnant, or if there is an imminent danger to an organ. Like if there is a nodule in the rectum, which is causing a block and the patient looks like they're going into obstruction, then we have to do a surgery to save their life. Otherwise, it can be catastrophic. Or if there is a nodule on the pelvic side wall that is entrapping the ureter, and this is very dangerous because it occurs without symptoms usually. So the ureter is the tube that connects the kidney into the bladder and drains urine there. Now, if this gets blocked, it creates a backflow onto the kidney and damages the kidney without any symptoms, and these patients can lose a kidney silently. Ooh. So it's a very, very catastrophic thing because it can go undiagnosed. It's very difficult to diagnose unless you know what you're looking for.
And I think I was watching one of your videos where you mentioned that the kidney results, like the renal tests, were fine because you have two kidnees.
Yeah.
And if one is functioning just fine, your tests would just show up fine, right?
Yeah. So we can't trust blood tests for that, because if one kidney is absent, your blood test would still be normal. If one kidney has shut down and gone into failure, the other one will show normal creatinine levels in the blood. So it's not going to affect. That's not how we make a diagnosis. We have to look at it on imaging and look at the size of the kidney and see whether it's healthy or not. And then we also do renal uptake scans, which are a little more complex in nuclear medicine. But that is to look for the functionality of the kidney, to see whether we can save it or whether we need to remove it.
One thing I can think of is in India, when you go to a doctor and your doctor asks you to do a lot of scanning and all of imaging and all of that, right? People sometimes get scared. They're like, इतने सारे टेस्ट लिख दिए डॉक्टर ने, and I don't know if this is prevalent in cities like Mumbai, Delhi, but I know in tier 2 cities for sure, if a doctor is writing a lot of tests for you, but like तो ज़रूरत भी नहीं है मुझे तो, even with blood test they're like, मुझे तो ज़रूरत भी नहीं है, मैं क्यों करवाऊँ ये टेस्ट.
Well, I think it's a natural evolution of things. Of course, there are going to be some seeds of doubt in that relationship. Back in the day, these tests were not available, and you would go to your family doc and he said, okay, just take these couple of pills and you'll be fine. And that worked most of the time, but a lot of these diseases went under the radar.
Yeah.
And medicine has changed so much since that time. And obviously we rely on technology. You have still 90-year-old doctors in some of our hospitals who are coming. I can diagnose everything with the stethoscope in my two eyes, and But those days are gone now. You have such good imaging in place. You have such good technology available. Yes, you can still reach your destination with a horse, but we have cars and airplanes and trains now. You shouldn't shun technology, and of course, there is going to be some. If patients don't understand why certain tests are being prescribed, I think that's what creates the kind of tension between the doctor-patient relationship.
Absolutely. There is a definite tension between the patient and the doctor, I think. In a lot of cases, women feel they're unheard. Like one of these cases, I was just talking to a friend whose sister was diagnosed with endometriosis, but very late. She had chronic constipation, like you mentioned. So she had chronic constipation, and she was only diagnosed when she was trying to conceive and she was unable to conceive. And I think she had a very late diagnosis. And my friend also has endometriosis. Her endometriosis diagnosis was delayed by 5 years. I mean, the cost of delayed diagnosis in this condition is just a lot, right? It affects your work, it affects your social life, it affects your you mentally. It's very traumatizing to be in pain all the time. So tell us more about if, let's say, one has been diagnosed, what are the next steps?
So it's a known fact that there are huge delays in diagnosis from onset of symptoms, anywhere between 7 to 10 years, depending on which country statistics you're looking at. And a lot of patients may not get diagnosed for even longer than that. There was a £500,000 payout to a lady in the UK who was not diagnosed or treated by the NHS and delayed 15 years of treatment. So that's a long
15
time.
years of treatment?
Yeah.
Actually, I can imagine that at NHS.
So there was a huge... it's a great landmark judgment, and there are gaps in the system where, unfortunately, women tend to fall through because a man in pain is taken a lot more seriously than a woman in pain in general, and there are a lot of the treatments available for endometriosis don't really treat endometriosis. They treat
the pain,
the symptoms.
Okay.
So you have hormonal therapies, which again act on the lining of the uterus, or they act on the hormones coming from the brain that act on the ovaries, that act on the lining of the uterus. So somewhere along the way, we're trying to use these medications to create a state of chemical pregnancy or chemical menopause, which we know doesn't cure the disease, but it does dumb down the estrogen so that the flare-ups associated with endometriosis may reduce, which also explains why hormone therapy may not work for everyone, because if it's an estrogen sensitivity or a progesterone sensitivity, and also the disease can make its own hormones even though they're in suppression.
Oh,
Yeah.
this disease is very resistant to everything, or it's quite difficult to then manage it also, right?
Yeah, we were mentioning that managing is of symptoms is one thing. So it basically works around reducing inflammation, where you either using medication or you're using physiotherapy or even diet to an extent. Unfortunately, we don't have tremendous data on what diet works, so it's more individualistic and what works for you. I don't think anybody needs to go raw vegan, cut out all dairy and gluten. That is not.
Really? Because that's a very commonly known, not fact, but maybe a lot of women do that. They try to cut down the inflammation part.
Yeah,
Is
but
that why?
you have to kind of figure out what is causing inflammatory changes to you rather than, deprive yourself of all the other nutrients just because somebody says now gluten is bad or this is bad or, that changes every couple of years.
And how do they do that? Are there any nutritionists who specialize in this?
I'm sure there are some. I work with a few, and for those patients who want to explore that, they do come up with a diet plan. But it should be more individualized rather than some cookie cutter
Absolutely.
formula.
So
Yeah.
a plain no gluten, no vegan, no milk diet may not work for everyone to
Yeah,
cut down
it won't work for
inflammation.
everyone. So obviously, if you have sensitivity to gluten and dairy, and if you have a glass of milk and it makes you bloat up, then obviously don't drink it
Yeah.
for the worst thing, which is so bowel endometriosis has a hyper response.
Okay.
So, like for example, me or somebody without endometriosis may get a little bit of indigestion or mild bloating with caffeine or dairy.
Okay.
Where someone with endometriosis has an exaggerated response, so they can completely get bloated and swell and painful bloating. And
Like you mentioned, what's called an endo belly.
yes,
Okay.
so that's the response. Now the bowel and the the gastrointestinal system, has its own neuronal pathway, so it's its own nervous system, so to say,
Okay.
and that nervous system has been upregulated for years, sending responses to the brain and back. So for that, even after removal of the disease, for that to downregulate may take a little bit of time. So that's where there's a lot more studies going on the gut and gut health and all of those things. And we're
Yeah.
seeing for endometriosis patients, of course, removing the disease makes a huge difference to them, but recovery is a process, while removing the disease is an act.
How long does it take to recover from the surgery? Is it quite intensive?
So it depends on what you mean by recovery. So a patient can be discharged either the next day or a week later, depending on what kind of procedure was done. Your basically any inflammatory healing processes within the body take about 6 to 8 weeks, and a good magical number is about 2 months or 3 months when they're completely better from surgery.
Okay.
But usually, the major pain related to surgery is done after about 2 to 3 weeks, where they can,
Okay.
go back to work and go out and everything like that.
Do women have to get multiple surgeries in some cases? Because I've heard of that. Like, I've heard that they might have to come back after 2-3 years for another surgery.
Right. So that's a big problem when surgeries are not done by experts. Like now, this is the most in its advanced stages. This is the most difficult surgery to do from head to toe among all specialties. And now you would never go to a general surgeon if you had a brain tumor and say operate on
Yeah.
this. So by no means should a general gynecologist be attempting to do something like bowel endometriosis or endometriosis along the nerves. So that's why it needs its own subspecialty. And when there are people like that who are not referring patients to specialized centers and saying, okay, I'll do the bare minimum and put the patient on hormones and, IVF or whatever. And that's why patients end up undergoing multiple unnecessary revolving door surgeries year after year. This problem should be kind of fixed at the root. And coming back to that ideology of the surgery should be one and done, but it should be one and done
Yes.
properly and not delayed until you can do a hysterectomy, which is still not a final treatment for the disease, because I have a huge series of patients who had hysterectomies and still had endometriosis left behind and needed another surgery after that.
Because it can grow anywhere, right?
Exactly.
It's not just around the uterus or the reproductive system. It can grow anywhere in your body, is what you
Absolutely,
mentioned.
yeah. Like I said, if it was in the rectum and you remove the uterus, it's going to still be in the rectum.
It solves no purpose. Yeah. And you mentioned that diet, there's limited research on diet, right? But when patients go to their doctors, a lot of times the advice that they get is manage your diet and lifestyle. Now, that's a very vague term, diet and lifestyle. What should you start running in the morning? Do yoga? How does it help you?
Well, I don't advise that. I
Okay.
would never say manage your diet and lifestyle. I mean, that's generic advice. You would tell that to anyone who walked into
Yeah.
your office, no matter what kind of doctor you were, because it's generally good advice.
Absolutely.
Eat well, get some exercise in, get some sunlight, walk a lot as much as you can, and, exercise, don't smoke, don't drink too much, and,
Yeah.
all of that. That's general good advice. You don't need a doctor to tell you that. I think that's common sense
Yes.
for most of us.
But yeah, that's so someone my friend's cousin was diagnosed with endometriosis, and this is what her doctor told, that you should just manage your diet and lifestyle.
But this is a very silly thing to say to somebody with endometriosis, because this is not a lifestyle disease. It's not like she was smoking a pack of cigarettes every day and she developed endometriosis. No, that's not true. This is unfortunately a hand she was dealt genetically, and of course there are other factors that determined how her disease grew and why it grew and so on and so forth. But this is absolutely not the fault of the patient, that it's some mismanagement of lifestyle that has resulted in the condition that she has.
Yeah, absolutely. Another question that I was sent by one of my friends, and she really wanted to ask you, that is, how much pain should be considered bearable with endometriosis? Because she's been living with this pain for so long that she needs to understand that, okay, sitting with a hot water bag the whole day may not be normal, but what's a normal amount of pain? And it's a very subjective question to ask too, to be honest. But at what point should she just rush to the doctor and say, okay, I think we need to look at something else?
Usually, if you're sitting with a hot water bag for the whole day, that's a big red flag to go see a specialist. At least get investigated for that. That's not a normal symptom. We see, of course, I've seen extreme cases where they've used hot water bags and electric blankets that cause burns on the abdominal
I've
wall.
heard of it too, yeah.
And that's there. And like we said, patients have endured multiple surgeries in these cases and not received treatments. And that's why the first surgery should be done properly. Unfortunately, because of my practice, I am rarely the first person to operate on someone. So most patients who have seen me have had anywhere between 2 to 10 surgeries by the time they find me and come to me. And I
2 to 10 surgeries.
Yeah. And I always say, I
That's-
wish I had seen you sooner, because now, of course, I have to deal with a very difficult disease that was not removed, but I also have to deal with the surgical adhesions that have formed where somebody has mucked about a couple of times before. So it's always, anyway, it's a difficult surgery to do, but when you have previous surgeries on top of that, it makes it even more difficult.
It must be so mentally taxing for the patient, right, who's going through 2 to 10 surgeries before finding the right doctor.
Yeah,
So,
absolutely.
okay, let's talk about some of the things one should look at when they're looking for the right doctor. Because this is also a very difficult process.
Yeah. Now, so one is, the societies still are not in the position where they're recognizing this as a specialty, right? So gynae oncology, cancer for gynecology, is recognized as a specialty, and most gynecologists would refer a patient with cancer to that specialty. Now, endometriosis doesn't fall. Now, this I know this because I trained as a gynae oncologist before I became an endometriosis surgeon, that the level of difficulty for operable gynae oncology versus endometriosis is night and day. Like, it is like running your town hall race versus running in the Olympics. The endometriosis surgery is much more difficult than gynae-oncology, yet there are very few recognized specialists. So the problem now, and even with the days of social media, is that anybody can, put out a nice Instagram post or, something on Facebook or YouTube and say, okay, this is endometriosis. I also treat the disease. But it's very difficult for patients to vet who is actually knows what they're doing.
Absolutely.
And so it's very important to ask one. I encourage patients to ask these questions. Unfortunately, the onus has fallen upon them to do due diligence while choosing a specialist, where you have to see, okay, do you treat anything else? That's the first one. Like, do you do infertility? Do you do deliveries? Do you do, urogynecology?
Okay.
So if a good endometriosis surgeon will not do anything else because it's such a demanding profession and a specialty that you don't really have time to do anything else. So that's one of the things. The second is, what is your volume of cases? And I think somebody who's doing about 150 plus endometriosis cases a year, advanced endometriosis cases a year, is a good level of surgeon.
Okay.
It's not. So the average gynecologist has never seen bowel endometriosis in their lives. A good laparoscopic surgeon will have seen 1 or 2 cases in a year.
Okay.
A good endometriosis surgeon will do 1 or 2 cases in a week.
Oh,
So
okay.
it definitely needs high volume and experience
All right.
when dealing with advanced disease. Yeah, I'm sure early superficial peritoneal disease only can be dealt with regular gynecology, where if they're trained properly, it's not a difficult procedure to reproduce. But doing the deeper advanced disease requires specialist care. Also, the other thing is, have you done a fellowship in minimally invasive gynecology? Have you trained with an endometriosis center? All of those things are things to look for. What are your complication rates? How many bowel surgeries do you do in a year? What are your leak rates of that procedure? Do you work with a multidisciplinary team? Are there many specialists around in case you need backup for, say, urology or cardiothoracic or bowel? All of those things are very good questions to ask someone who may be offering treatments for endometriosis. It's very difficult. I think patients kind of have to, one, look at where they are. There are excellent support groups online that have, doctors that have been vetted, and patients share their experiences about certain doctors, and so on and so forth. So, but that is also a bit of a double-edged sword because it's experiential. So somebody may have a good experience, somebody may have a bad experience, and you know how it is.
Yeah. And I think comfort level with the doctor, how freely can you speak to your doctor about the problems you're facing, and also how well it's being validated. Because I think, like, I'm talking to you right now, and I feel, yeah, of course, if you would to talk to your patient, you would obviously validate their concerns and talk to them about the problems that they're facing. But in a lot of cases, that does not happen.
Right, of course.
Unfortunately, that exists, and
Yeah, so it comes down to what you're looking for as a professional, medical professional. You're going to ask questions that are relevant to your specialty, what you feel may be relevant to your specialty. And if the patient is telling you, oh, I have shoulder pain, or I have pain when I move my bowels, like, okay, that's not my headache. Let somebody else figure that out, okay? At the most, they'll do refer to gastroenterology and leave it at that. They're not going to look for bowel endometriosis or something. So
yeah.
that, I think that connection has to happen in the brain in the intake process of seeing a patient to start making those diagnoses.
Which is why it's important to find a good doctor
To listen.
Yeah. Like you mentioned, each session is about 40 minutes long, and I think on an average, when you go to visit your doctor, they take about what, 5 to 7 minutes to listen to your symptoms.
Right.
And then yeah. And I was quite surprised when you said 40 minutes, because that's basically like a normal doctor would see like 10 patients 8 patients in that time.
Yeah. Like in certain practices, you will get penalized if you take that long to see a patient. If your practice is being run by a hospital, obviously, I have an independent practice, so I don't know. So they're like, why are
Yeah.
you wasting resources seeing a
Yeah.
patient for so long when you should be making this diagnosis? So,
No, but I'm sure this conversation will help a lot of women. Another thing is, what is adenomyosis? I've been reading up about this. And is this linked to endometriosis?
yeah, I say it's like the evil stepmother of endometriosis.
Okay.
Adenomyosis is disease in the wall of the uterus.
Okay.
Now, it is, you have endometriosis kind of tissue that grows in the wall of the uterus. Endometriosis grows outside the uterus. Now, adenomyosis can permeate through the wall. So, you usually see rectal nodules that are stuck to the back of the uterus always have some kind of posterior wall adenomyosis or adenomyosis of the back of the cervix. Sometimes you can have bladder endometriosis that grows from the adenomyosis in the front wall of the uterus, just below the bladder.
Okay.
So it can be a continuation outside that can form endometriosis.
And the symptoms are similar?
Similar, you have midline central pain, you have lower back pain, you have bloating because it inflames the bowel that is around it, and also can have painful intercourse as well. And the fertility issues also come some with adenomyosis.
Okay. And can these two also coexist?
Absolutely, yeah.
Oh,
Very well,
God.
very, very common.
Oh, that's quite common?
Yeah, adenomyosis and endometriosis are pretty much like peas and carrots. They usually, more often than not, go together.
Okay.
They're both hormonally dependent conditions. They share similar characteristics under microscope as well. Fibrosis surrounding endometrial glands and tissue, glands and stroma, and adenomyosis. Of course, the best treatment for adenomyosis is a hysterectomy when
Yeah.
it's symptomatic, yes, but that also encompasses treating the endometriosis as well. So, yes, for adenomyosis, by all means, do a hysterectomy if the patient is, wanting one or is horribly symptomatic and needs one. Then the hysterectomy is indicated,
Okay.
but also it is imperative to remove the endometriosis as well.
Okay.
There are many, people who will say, "Oh, I put in a laparoscope and I was surprised to find a frozen pelvis." One, this should never come as a surprise. You should diagnose this clinically. Frozen pelvis comes in a clinical setting where everything is stuck together, and it felt initially like a block of ice. So that's how they came up with the term frozen pelvis. So it should never be a surprise finding in a laparoscopy. And even if that is found and the surgeon is not capable of finishing the surgery, they should not start the surgery. There's no shame in abandoning the surgery and referring the patient rather than doing a half-baked surgery and expecting the patient to go somewhere else for another surgery after that.
That'd be so awful.
Yeah, there's a very
Yeah.
important saying. It's knowing how taking off the plane is optional, but knowing how to land the plane is mandatory.
Mandatory, yeah.
So which means that if you start the surgery, you should finish the surgery, not just do a half-baked job.
So, do you also do surgeries for both adenomyosis and endometriosis?
Yeah, of course. We have to
Okay.
you have to be able to treat both. You can't treat one or the other. You're kind of most of the time duty bound to treat both. Adenomyosis is tricky in some cases in younger patients desiring fertility. You can either not do anything or you can remove a portion of the adenomyosis, which is called an adenomyomectomy, and then reconstruct the uterus, or eventually the hysterectomy for those who may not desire fertility.
Okay.
It's more difficult than a traditional hysterectomy because what gynecologists are taught while doing hysterectomies is called the hug and pray technique, which is where you hug the uterus and pray that you don't hit anything laterally. But an adenomyosis, especially in a setting of a frozen pelvis, you cannot do that because
Yeah.
you're going to end up leaving all the disease behind. So you have to do a wide excision, similar to what we did in oncology for radical hysterectomies, where we have to go all around the disease. We have to follow a similar principle of surgery for
Okay.
adenomyosis when we're doing a radical hysterectomy along with that for the endometriosis and the adenomyosis.
All right. And now that these two coexist, can there be a misdiagnosis between the two, or imaging makes it quite clear whether it is adenomyosis or endometriosis that one person is suffering from?
No, the imaging makes it very clear. So the uterus is pretty easy to see. If there is outright blatant adenomyosis, it usually gets picked up quite well. Sometimes a focal lesion can be mislabeled as a fibroid, but that is due to an error in reporting. And we have a good criteria that have come out now to show certain findings that appear on ultrasound that allow us to describe adenomyosis. So
Okay.
those are listed. There's papers published about it, and those should become standard of care soon.
All right. All right. Are there any supplements that can help with these conditions?
Supplements are interesting because they work to reduce inflammation, but they don't necessarily have to go under FDA approval as such, or DGCI for us. So we don't know very much about them. There's no huge studies on most supplements. There are some, of course. There's good literature out on curcumin, for example.
Anti-inflammatory.
Yeah, so anything that
Omega
works.
3 as well, I would
Right.
assume.
So a lot of people do use those things with some success, but I would not put it at the highest level of evidence. So it works for some, it doesn't work for the others.
Yeah. We're almost coming to the end of this episode, and we've had a lot of good information from you. Um, if you were to give one advice to women who have just been diagnosed with endometriosis or are thinking about, going in for the scans, imaging, are trying to find a doctor, what would that one advice be?
So unfortunately, the advice is do your due diligence and be very open about discussing your symptoms. They should not be in fear or in awe of the doctor and fear that they may offend him or her by saying, are you able to do this? And if you're not, can you refer me to someone who can? Ask the difficult questions. There's no harm in it. There's no shame in it. You have to have that uncomfortable conversation with your care provider, because at the end of the day, this is your body, your health, your life. And so I think you should take the best care of it and make that decision in the best way possible.
Thank you. That is some amazing advice. I have one more question, which I think is very relevant, because you mentioned, right, if men were going through so much pain, I'm sure we would have had a solution for this. How well funded is the research around endometriosis globally, and what kind of research has been put in?
It's terribly funded.
It's
It's pennies on the dollar at best. And of course, like I said, if it affected men as much, they would have thrown billions at it. There is a huge economical burden because of this disease. Apart from, of course, the physical, emotional strain, not only on the patient, but on their families as well. And I think that is why we have to work towards creating more awareness. A lot of my colleagues in the US are patient advocates, and they work to get bills passed to get more funding for endometriosis research. Currently, globally, a lot of the research that is going in is still going in the wrong directions for most things. A lot of them are pharma funded, and they're not looking at the right drugs or the right treatments. And a lot of them are, they just keep dropping a random headline in a random, like the Herald or something like that, saying breakthrough in endometriosis care, and they basically just rebadged a new drug in an old drug in a new bottle. There's a lot of slow progress in endometriosis research, and in India, and I think most specialists in the world are in private care. So research is not funded, and if it's something, you do it out of purely academic interest, or you pay for it out of your own pocket, especially in India. The hospital is not going to give me money to do research.
Yeah.
I have to, pay for it out of my own thing, or make sure I keep documentation and fellows and research analysts to publish whatever we publish. So I think that is a big problem in terms of moving forward towards a cure, a non-surgical cure. Um, Hopefully it'll happen one day, and then we
Yeah.
can.
Hopefully, yeah, because we do need a lot of more research in these fields, because I don't think even with PCOS, right, there's not a lot of research that has gone into knowing what causes it.
Right. Yeah. PCOS, interestingly, is more probably better research than endometriosis.
I I don't know how to what extent though, because the cause is still unknown, right?
Right.
Like we still don't know if it's lifestyle or genetic or could be anything, right?
Right.
So I do think that we need a lot more research, and we need a lot of doctors like you who are going to be patient advocates.
Not like me. So the research stuff and all needs very intelligent people. I'm just very good at removing the disease. I'm not good at figuring out
But
what
you're a
caused it.
patient advocate, which is great. We don't have a lot of those, and we definitely need that in our country. Thank you so much, Dr. Abhishek. I'm sure a lot of women are going to benefit from the information that you've provided us. I'm sure a lot of women will now speak up and speak to their gynacs, go to specialists, and get the right information, get the right treatment, get early diagnosis. I hope this information has been helpful for you. If you want to reach out to Dr. Abhishek, you can go check out his Instagram page. I will be linking that in the bio. Thank you.
Thank you. I hope you enjoyed this, whoever is watching, and thank you for hosting, and what wonderful, insightful questions.
Thank you so much. This was a lovely conversation.